Absolutely.
Thank you very much, Ramurthy, for the nice introduction and also the fantastic panel here. Thank the J&J for this wonderful opportunity and the wonderful symposium as well. These are my financial interests. What are the keys to the refractive cataract surgery? You increase your refractive accuracy, but good biometry, address the astigmatism, decrease the complications like avoid capsule issues like corneal edema or cystoid macular edema, choose the best quality, visual quality IOLs, and exceed the patient expectations, under promise and over deliver. Hard brown cataracts, as you know, is a challenge to the phaco surgeons because of the difficulty in the posterior nuclear plate. That is a difficulty to crack the nucleus because of leathery attachments, thin posterior capsule, large nucleus, poor or no cortical cushion, increased incidence of corneal edema and postoperative corneal decomposition, increased incidence of PCR and nucleus drop as well. So you need to combine the technology and the technique, and that's what is the basic aim of the symposium, how we combine the technology and the technique. And the technology is available in the form of really all the phaco machines like Signature Pro, the Centurion, or whatever, Infinity, and Stellaris, whatever it is. You can see this brown cataract. It's like a piece of granite inside the eye. And make sure that the corneal endothelium is very good in these patients. A lot of protocols you need to do, have a careful pre-operative protocol before we do this patient. If you have do the conventional phaco, sometimes you can end up in a corneal edema like this, but may clear up in about a month or so. But the problem is, this corneal edema can be associated with a lot of prostaglandins or inflammatory cytokines being released into the eye, and something like this, what is called the toxic anterior segment syndrome or the fibrin reaction, which is there on the surface of the IOL. And 25% of the corneal edema can have a problem in the retina, which is called the cystoid macular edema, which may be sometimes very refractory to treatment as well. And these are the post-operative pictures. You can see the femtophaco, the clear corneas as well. Just to show you how I do the conventional, the technique of the manual phaco in a hard brown cataract. I always do a rhexis, which is about 5.5 millimeter, not more than 5.5 or 5.6 millimeter approximately. I don't want the rhexis to be too small. I don't want to be very big. I want the rhexis to be a little on the larger side because I need the space for my chopper. You can see here I'm doing this. These are the parameters I use on a Stellaris PC machine. I use my chopper there, the sharp chopper. I can see here how much of phaco energy I have to do this to open up the posterior nuclear plate. Every time I dip into the nucleus, I need to use phaco energy, which means that there is a certain amount of heat which is delivered into the corneal endothelium. And every time I dip into the nucleus, I need to open up the posterior nuclear plate, which is going to and you can see the effective phaco time is almost 25 seconds. What is happening in catalyst? Manual phaco is something like the Sachin. The Sachin is good in one format of the game, whereas Dhoni is good in all formats of the game. Okay, whether it's T20 or one day or the test match, because that is where I think the catalyst of the femtophaco plays a role, because the entire spectrum of cataracts, whether it's hard brown cataracts, subluxated cataracts, posterior polar cataracts, even for soft cataracts, I would say I would recommend this because patients coming with very good vision, you want a safe surgery. The vertical spacing I would reduce by about in hard cataracts about 25, and grid space horizontal. We don't do this, the softening of the cataracts. The pulse energy is about the same. The rock hard cataracts, I do the vertical spacing much less, which is about 20. And normally in the softer cataracts or the medium cataracts, I do about 40 the vertical spacing. Here I do 20 because I want the what you call the openings to be, or the spots to be closer to each other. You can see this is a hard cataract which I'm going to. I just quickly go through some videos here, wherein you can see here this is a fairly hard cataract, and you can see the rhexis is already done. One of the biggest advantages, I think Kumar beautifully mentioned that, is that there is a cutting of the, already it's pre-cut. It's like a pre-chopped nucleus. So I'm just using a Sinskey hook there to open up this, the entire posterior nuclear plate, because already the posterior nuclear plate is opened up. I just have to use, you can use any instrument for that matter. The Sinskey hook is more than good enough. You can see here how it is there. And I don't use much phaco energy. I just go there, dip there, and open up the posterior nuclear plate, and the entire thing comes out. And we have excellent missions with fluidics like the Centurion or the Stellaris. The followability is very good. You can actually stay there, and automatically all the pieces will keep coming to the thing. Now and then I inject visco. This is a routine in all my brown cataracts to make sure that my corneal endothelium is well protected. So just to show you this, another patient with a little more brown cataract, can see it's a grade 4-5, very dense brown cataract. Invariably, I make the main incisions in almost about 50-60% of the cases, unless the patient has got a dense arcus inless. Side port incisions I don't make, but this is just a early case I just want to show you. But the incisions also, I want to make sure that the incisions are good incisions for me, but do these hard cataracts, because the triplanar incisions are very important. Don't do too much of hydrodissection. Already certain amount of gas dissection is there, and make sure that, because sometimes you can have an hydro rupture. You can see how these cataracts open up very beautifully. The very fact that the gas bubbles are coming from the front to the back, it means that the posterior nuclear plate is already opened up. Means so you can go bevel down, bevel sideways, bevel up, whatever you're comfortable. You don't know to do, need to do any trenching. That is the advantage of these cataracts of this thing. You open up this thing, and the opening up the posterior nuclear plate is the most important thing in these hard cataracts. Once you open it up, you can easily gobble up these cataracts without any problem at all. I can see that I'm just separating the central one, and the rest is very, very easy for anybody. Okay, you can just stay there and even close your eyes and operate. That is one of the things which you can do. Again, you can see here another patient with the fronto black, almost brown black cataract. You can see here the rexis is taken. I always use a do, making sure that it's in free floating rexis, and just do sometimes they do a small trench, but it's not necessary invariably, and you can open up the nucleus without any problem at all. And whether you use a sharp chopper, I use normally a sharp chopper, the Mohan Rajan chopper made by the Apasami. I don't have any financial interest in that. Just to open up the posterior nuclear plate, because I already opened up the pre-cut, the pre-chopped nucleus is already there. Just to show you of cornea, dense cataract with the cornea guttata, 1000, the count is there. I'm putting a toric lens, and can see here how this surgery proceeds with the femtophaco. Absolute indication for a cornea guttata or a fused endothelial dystrophy with the dense cataract is this, because you do have very, very less phaco energy, and the corneas are fairly clear, and you don't have much loss to the endothelium as well. So I'm using a Centurion machine here and just doing everything, and just chopping. I'm using a similar what do you call the chopper, the regular chopper as well. I can see that already the cut is made. I just have to open up that. I just have to hold the right side of the nucleus and open up in the crevices which are already made. I can see the gas bubbles are coming up, and the rest is very, very easy. Just to show you that you can even open up the entire this thing with even a Sinski hook, just to show you. This is a femto after this very bad sick cornea, 2 hours, and after 2 days also you can see that the cornea is crystal clear as well. Just to show you in black cataract, okay, many people say, no, don't do even phaco. But the problem is, the advantage of the femto is that in black cataracts, dense brown cataract, you can see that I'm doing a trenching here. I'm doing a manual phaco. You can see the amount of phaco time is about 33 to 35 seconds in this particular case. But how every time I have to go inside, I have to penetrate or bury the phaco tip. I expend some phaco energy, and I have to open it up. I have to do lateral separation. I have to go all the way down, whether they use a sharp chopper or a blunt chopper, whatever it is, that every time, and the surgical time is also a little more. Just to show you this hard cataract, which I did live surgery in the surgical strikes last year with the catalyst, and the almost a black cataract. You can see here how it is easy for you to open it up. See, because I did do the octants, that is the 8 quadrants in these cases, and you can see how it is opening up very easily. Not much phaco energy. The phaco energy is only approximately 12 seconds, the entire effective phaco time. The amount of phaco energy is very, very less. The amount of surgical time is also very less, because already it is pre-cut, and you just have to go inside and do. I'm using a Signature Pro machine in this particular case, and can see the followability is really fantastic. I think Kumar has beautifully mentioned about the features. These are all the various brown cataracts you saw and all the post-operative pictures. Crystal clear cornea, the pristine wounds, no corneal burn. You can see here no corneal burn, pristine wounds in day one without any problem. Again, white cataracts also, the Argentina flag sign, the intermittent cataract is a huge problem. And this is a 100% what you call foolproof method, I would say. Femto cataract, you can go ahead and do this thing without. Only thing is when you are doing a rexis in a femtorexis in a white cataract, look for skip lesions. Don't try to pull the capsule out like the way we normally put, because normally it's a free floating capsule thing. In a white cataract, look for skip lesions there and make sure that you are, otherwise you can end up in tags which can extend to the posterior capsule as well. Many people say this is just to show you that
can you conclude, please?
Yeah, I'll wind up anything. Take home message is flax is in complex situation. White cataracts, hard brown cataracts, posterior polar cataracts, subluxury cataracts, fuchs endothelial dystrophy, and corneal guttata. All these complex situations are very reduced surgical time, reduced effective phaco time, more precision, clearer corneas, and reduced complications, safety, precision, bladeless, consistency, wow effect, good platform, differentiates the practice from other practices as well. Thank you very much for the wonderful opportunity.